Well, good morning. Welcome to TCTAP 20th anniversary. This is our first endovascular session, and this will be an exciting live case session here for the first hour and a half. I'm Bob Bersin. I'm joined by my co-moderator, Dr. Kazushi Urasawa, to my left, and we have a distinguished panel here of endovascular specialists to help provide commentary. And I'm very pleased to announce that we have live transmissions coming from Asan Medical Center, 2 different transmission rooms, and in a moment they'll start broadcasting. So welcome to this exciting session. Good morning.
Good morning. Bob, Mark Burket here. Can you hear us okay?
Yeah, we can hear you beautifully and see you very well as well. Bob Bersin here, joined by a distinguished panel. To my left here is Dr. Kazushi Urasawa, my co-moderator. We have a distinguished panel of at least 10 different endovascular specialists from around the world, so good morning.
What about checking TSA and
We need to treat that.
Yeah.
Okay, so we've got a great case here. I think we're ready to present it. I think this will foster some pretty good discussion there, Bob.
Yes, our patient is a 78-year-old male. The chief complaint with right leg clavifications. He already underwent stent implantation for both internal carotid artery stenosis 7 years ago, risk factor HRL, diabetes, hypertension, and dyslipidemia. Next one. His ABI is 0.53. Yeah.
Are we able to show the CT scan?
CT 좀 보여주실 수 있겠습니까?
Well,
All right, Bob, do you see the CT there?
Yeah, we can see the CT and the runoff. Boy, you've chosen a very difficult calcified CTO here. We see this very well.
So later today we'll be talking about CTO strategies, and tomorrow we'll be talking about calcified vessel strategies. We've got them both in a big way in this case. So our initial thought was to approach this from left groin access, crossover, take a shot down the right leg, and see if there was something we could do in the femoral popliteal segment. So I think what we'll do is we'll kind of take you through what we've seen so far. If we could go to the most recent angiogram and show that to the audience, please. Can we go to the most recent angiogram that we did? Okay, and then go one back from there. So just getting access was kind of interesting. As you can see, there's a rock pile in the aorta and the iliac arteries. It was difficult to get a wire to traverse, and then after it traversed, we had to switch out from an omniflush type of catheter to a hydrophilic catheter just to track down to get right leg angiography. Also making life interesting is he's significantly hypertensive with a blood pressure over 200 and has already developed a left groin hematoma. So now we'll go to the first right leg angio.
So Mark, it looks like
the calcification.
So Mark, it looks like the right common iliac's pretty significant. It looks severe. Does that need treatment also?
That's right, and we just discovered that about 15 seconds before we went live, which I think is going to alter our strategy here a little bit, Bob. But you can see, are you getting the replay right now on the femoral shot?
Yes.
Okay, so as you can see, truckload of calcium really starting in the common femoral artery. There's a significant compromise in the origin of the profunda, which after that initial narrowing actually is a pretty healthy vessel, very dominant, supplies a lot of collateral down to the popliteal. You can see that there's an acute angle between the origin of the SFA and the profunda, a lot of calcium in the SFA, and enough of a stump that should you choose to go after it, at least you know where the SFA is. Now if we could go back to one of the earlier shots that shows the reconstitution in the popliteal. Be the first angio run that we did. So there you can see a really extensive calcification throughout the whole SFA segment, then reconstitution around the adductor canal. I think there are some stenotic areas, but overall we have a good diameter of a distal pop. Nice runoff through the perineal, which sends a communicating branch over to an occluded posterior tibial. So I thought this might be a good point to kind of open it up to a little panel discussion. We've certainly got a distinguished panel there, and what are some of your thoughts about the approach to this?
Well, Kazushi, why don't you start off?
Sure. Yes, it looks like a very difficult regions because very severe calcified regions, but it looks like some channel within that calcified regions. Maybe the real CTO length is much shorter than expected, I think.
And then why don't we just work our way down the panel? Just comments about how you would handle this?
I guess we are down contralateral approach. We can park one of the catheters at the beginning of the SFA and work down through a wire. And maybe at some stage we might need to think of an atherectomy.
Okay.
The first of all, this case is a single level disease, or I would say the iliac level is okay or not. Mark, I would like to know that because if
sorry, is
single
okay?
single level disease is this is very tough. Even after success wiring and stenting, chances of the stenosis is very high. So
right.
I would think the successful wiring, what you're going to do after that? That's a problem in this case.
Uh-huh.
Yeah, perhaps part of our strategy depends on how we get through. Huh? And so perhaps we poll the panel. Who would start with basic wire technique, trying to stay luminal? Who would just go deliberate subintimal? Start there.
Good morning, Dr. Burket. This is Dr. Ra. This is actually non-total occlusion. We can see the definite flow from the SFA ostial opening. So problem is a very calcified region. So if I treat this, maybe the right iliac ostial disease, because this is inflow disease. Before the SFA treatment, I will do the contralateral balloon angioplasty alone. Then later on, after finish the SFA treatment, while coming out, we can do the stenting in the iliac ostium. And SFA, in the especially proximal portion, it's better to do the debulking using the silver atherectomy. For my cases, because it is a very important bifurcation area in the proximal and the very calcified area. Silver or turbo will work in the focal area. Then we can do the non-compliant balloon to come down on the entire significant region. Then we can consider the DEB or the spot stenting. That will be usual my procedure.
Okay, any comments from the right of the panel? Time's marching on. You have a lot of work to do, so we'll just get one or two more quick comments about approaching this. Lawrence?
Hey, Mark. Lawrence Garcia here. Good luck with this.
Hi, Lawrence.
Hey. I think that if you, just looking at it at face value, I think the common femoral is probably your critical lesion. I bet you this is from his iliac, if it's all claudication from what I saw on the upfront presentation. So fixing the inflow and probably this common femoral may get you out of significant claudication, but I don't think, and I tend to agree with the last speaker, that I think looking at this common femoral, I think you're going to have to deal with it to get everything set up to include your stent and your SFA. That's kind of my approach here.
Any more comments?
Those
then
are
we'll
very
get
good
to
comments.
Excuse me. So I'm Osami from the Osaka, Japan. So could you show us the supersective angle from the proximal SFA to appreciate whether the region is stenosis or total occlusion by using a DSA image? Because there's a much of a classification. Could you show us?
I'm not sure if we have a DSA option here.
Oh, really? So, but we need to appreciate whether the region is stenosis or CTO. So usually we use the supersective angle from the proximal SFA by using the microcatheter or small catheter into the proximal SFA.
Yeah,
what do you think of such
I think we could certainly get a catheter in there, and even though there is what appears to be a stump, I do think you can see a little sliver of dye going beyond that. So we could certainly see if that's the case. I can kind of jump forward to what we've been thinking as we looked at this. There are a number of concerns that we have. One is, as Lawrence pointed out very well, there's probably a 50% luminal compromise throughout essentially the entire common femoral, calcified, and I think anything short of atherectomy probably is not going to deal with that. And then we jump immediately down into the bifurcation, which is compromised on both sides, kind of an acute angle. And anything other than a perfect result at that point will compromise the profunda. Then we have a long area of very heavy calcification, which if we get if we can go true lumen and then do atherectomy and get a great result, we'll be okay. But short of that, and particularly if we go subintimal and need a more supportive stent approach, like an IDEV, that's one of the options that isn't available. So we would have to go with a slotted tube nitinol. And I'm not very optimistic that we get a durable result that way. So one of the things that we've been discussing here is he's already had a pretty good trial of cilostazol on conservative therapy. He has vein intact. He's an otherwise healthy elderly gentleman. He'd probably be better served by a venous fempop bypass than by us getting a result which is not durable at this location. With the inflow iliac disease, I think that's probably our first priority for today, and we will probably get to work on opening that up as kind of our first line of work here.
Okay, comments from the panel? That's not an unreasonable approach. Question is whether to do anything with the common femoral at the same time to improve flow to the profunda. Comments from
I think that's a good question.
You know,
We've actually had reasonable results with a fairly simple approach of using an angiosculpt at this location as well. Any comments about that?
Yeah, I think it's going to be hit and miss in regards to its dilation. I mean, the plaque volume there is going to be extensive. The unfortunate truth is we just don't have any data to support, the endovascular approach to the common femoral. We're doing a pilot study right now at our institution looking specifically at directional atherectomy plus drug-coated balloon versus endarterectomy there, and hopefully that'll provide at least some signal. Because I think that if you just treated that and got the profunda open with the origin of the SFA, including your inflow, you probably could have a reasonably good result from a claudication standpoint that you don't have to then, play that trump card of a fempop bypass just yet. And I suspect that will give him enough sensatory relief that he'll actually be less claudicative.
Right, right. Two basic strategies. If you're committed to the FEMPOP, you can leave it alone, and then it can undergo endarterectomy and patching at the time of bypass. Sure. But I kind of agree with Lawrence. If you improve flow to the profunda and the common iliac, it may be sufficient. The patient may be converted from a level 3 claudican to a level 1 or 0, in which case then you don't need surgery.
I think that's right. We, as I mentioned, we discovered the common iliac about 15 seconds before we went live, but that really throws a whole different management approach to this. And it looks, if we could go back to the common iliac stenosis, to my eye, that looked pretty significant. We have not yet measured a pressure gradient across it, but I think that certainly may change the dynamic by itself. And then if we can get any additional improvement in the common femoral and profunda, that's kind of icing on the cake. But that common iliac looks pretty tight.
It does.
So I think what we'll get to work on here is working on that common iliac. And you have another case in the other room. Is that correct, Bob?
Yes, we do.
So do you guys want to switch over there while we get to work on the common iliac?
Okay, why don't we do that? Go ahead and start your treatment there, and we'll get back to you.
Good, thank you.
All right, thank you. All right, if we can go over to the other room now, we have the Dr. Lees, two Dr. Lees.
Okay, let's look
Good morning.
at the...
Good morning.
Morning. We can see you, hear you very well. Dr. Bob Bersin here. We have a distinguished panel. We just left the other room where they're working on an iliac and common femoral. Tell us what you have today.
Yeah. This patient is a 71-year-old male. He presents with prolonged right leg claudication. And CT angiography outside the hospital showed the total occlusion of right SFA from the proximal SFA, and the reconstruction is occur in P2 level. And his risk factor include previous stroke, diabetes mellitus, and hypertension, and dyslipidemia. 4 months ago, he presented with the critical limit ischemia in left side, so we fixed up the left SFA and the below knee, so wound is clearly healed. So the patient is now today prepared for the right SFA total occlusion.
Would you show the CT angiogram on the screen? No. CT angiogram. 그 3D reconstruction 한 거 보여주세요. 끝에서 두 번째 거요. Okay. You can see a total occlusion of SFA from the proximal to the distal adductor canal level, P1 maybe. 아래쪽 보여줄래요? 더 내려주세요. CT 계속 돌려봐줘봐요. 아래쪽 BTK. CT 엔조그램 BTK 보여주실래요? 네, 그거요. 아니요, 맨 밑에.
맨 밑에 거.
그렇죠. And there is a total occlusion of 좀 돈 없는 걸로 보여줄래요? 뼈 없는 걸로. 다음 거. 다음. 뼈 없는 거요. 뼈 없는 거. 그래. 맨 마지막에 두 번째. BTK. 오케이. 좀 돌려봐요. As you can see, there is a total occlusion of posterior tibial artery from the proximal to the ankle level.
So we visualize angiography in iliac bifurcation.
angiography 스크린에 띄워주세요.
Is you can see.
And so, I'm sorry, the symptoms on the right leg now are currently claudication or
claudication. Claudication. Left side is already picked up 4 months ago for the critical limb ischemia.
Right side is no wound, right?
No wound on the right side.
Yeah.
Side. So
this is a Rutherford class 2 claudication.
Yeah, target will be only SFA.
For the right side.
Yeah. Today, SFA. So you can see the complex iliac bifurcation. The omni catheter was engaged. Next, okay.
And
next, we advanced
omni-catheter to the distal rubber, and the guide wire was switched to stiff and flat wire. And today we use shuttle sheath for the possibility of treatment of PTA rubber. If we want to treat only SFA, we usually use anesthesis, but we want to treat the PTA rubber all together today, so we use the long shuttle 90 cm, 6 branch. And this is the baseline angiogram.
This is the reconstruction of the popliteal artery.
And this is the
This is the proximal portion.
ostium.
So, any suggestion, any comment?
Yeah, so here we have another task D lesion, 20 cm plus, so the SFA. The first one in the other room, they're considering sending that one, referring that one for a FEMPOP bypass. How about this one? We can't really appreciate the degree of calcification. I don't know if you can show us a fluoro image to see how calcified or non-calcified it is. But this one has a reasonably good stump and reconstitutes above the knee. Let's take a poll of the panel. How many of the panel are routinely approaching task Ds like this with intervention?
In Korea, currently we have very good CT wires. So I would start with the 18 system connect flex from Abbott Vascular. And once that is not working, maybe we can try the Asta to 12 gram 18 system, or further negotiation with the more stiffer wire, like a 250 T, connect, or the Asta to 30 gram. But if the intraluminal wire is not feasible, we can either choose by the subinternal approach to the Battista and re-enter, or the just retrograde approach from the distal SFA. That will be the usual approach of our current situation.
So we have one vote for wire-based intervention for this task D. Show of hands from the panel. Who would approach this interventionally, regardless of how you intervene? Surgically?
I'm Yokoi from Japan, but angio, you have to measure the region lengths, proximal regions and distal regions, and you have to guess a lot about region lengths.
More than 20.
Okay, well, most of the panel would approach this interventionally, so tell us what you're going to do.
Yeah.
The region length is around 50, 15, 20, 25, maybe 30, 25 or 30 centimeter.
This moment. So our team decided to.
So we're seeing some loop wires.
Insert the wire on the guidance of the balloon 4.10. Balloon was supported, and this is
we initially started the subintimal angioplasty because this reason is too much long for the intraluminal approach. So we use initially with multiple pulse with angular J thermal, but the reason is a little bit calcified and very hard, so it is very difficult to negotiate the CTO in the shaft because it was very hard. So we use 4.0 millimeter balloon for the anchoring to advance the wire, but the wire is too much softer than the region. So we changed the guide wire to the steep thermal with the anchoring technique. And the guide wire can be passed the region, hard region like that. And fortunately, there is some scattered calcification and hardness can be negotiated by this anchoring technique.
So here we're seeing the deliberate subintimal approach with loop wires. Now the loop is getting a little large here, but it's still acceptable.
I know. So we try to make it a small loop. Like this?
Eventually, the guide wire passed that calcified region like that, and we passed the hard portion subintimally, and we reached the distal landing zone like this. Then we check the angiogram here.
And the target region is very long, looks long. It's worth it to try with the intraluminal wiring, so at least once. Anyway, the problem
maybe
is SFA sub-interangioplast, for me, I think it's better to use the smaller loop, 3-5 wire. Like you have 1.5J. That is instead of
so
this.
initially we used the curve, but it's unsuccessful because that thermal wire is too much softer than this reason, so we changed the stiffer wire.
Intraluminal wiring in this kind of situation, maybe it takes 3 years.
Some Japanese doctor do ultrasonography intraluminal approach, but we are not familiar with the technique. And finally, we try to re-enter the true lumen with the small angled J thermal, the tip of the substitution, but it was very difficult. So we changed the guide wire at this portion with
he's getting close now.
30 gram. Yes.
Yeah. However,
after 30 gram, we import for just 3 or 5 minutes, but it was very difficult. So.
Yeah. So the reentry here is
this is the current situation. Yeah.
A lot of times on the degree of calcification, those that are heavily calcified, it's very hard for a wire to pierce.
Bob,
so from now on, you decided our.
So,
sure,
Sensei Urasawa and Yokoi in Japan, it's the rendezvous technique which seems to work the best here. Would you routinely access from below as well as coming from above in this type of case?
Sure. Maybe 50% of my case was bidirectional. Yeah.
I think because in Japan you don't have the re-entry device.
That's right. You're right. Yes, we don't have.
So in my case, I usually because we can quickly use the outback catheter or re-entry device.
Yeah.
Or to prevent the distal dissection extension, or just to retrace the puncture. I think either way will be fine for this situation.
Mm-hmm. Yeah, we have the
for the re-entry device.
Well.
Actually, wire re-entry is very difficult. Maybe it's nearly difficult. So it's better to shift your strategy.
Yes. Yeah. In this case, there is already a big sub-intimal space around the wires. It makes quite difficult to penetrate through the distal lumen using a very fine 0.14-inch guide wires. Maybe I think it's time to switch to bidirectional or using the re-entry device at this point.
You know, personally,
excuse me,
I
Dr. Lee.
seldom use a re-entry device. Yeah.
Dr. Lee, I'm Sam from Osaka. So this is a common feature in the SFA schedule intervention. So before considering the retrograde approach, we usually use the angled chip catheter, which is a Boria catheter, to penetrate the distal chip with the use of the CTO dedicated to guide wire, 1814 CTO guide wire, which is Astat or Treasure or something like that. What do you think of such kind of approach in these situations?
Yeah, I think so. In this kind of situation, you need an angled catheter, the CXI or whatever. Unless you are doing the same way. And as Dr. Urasawa mentioned, you have to think of the time to stop and give up for retrograde approach. Could be a choice.
Angled catheter is very helpful to negotiate the region, but Astato is very strong enough to negotiate the curve. So the Astato 30 gram is very strong. Without angled catheter, it can make a curve, it can make its load, but it is a little bit difficult. So we changed plan to retrograde puncture today.
Maybe try it a little different level
maybe the puncture.
So, Dr.
Yeah, we wanted to puncture pit.
Dr. Lee, again, which wire are you using currently? What wire is in there now?
This is Astato. 30 gram.
30 gram?
Mm-hmm. So when you imagine...
Very strong.
Very strong.
Yeah, even
like
strong. So you just imagine that even you are using the outback catheter, the penetrating needle is much stronger than this Astato. But in this situation, we can effectively penetrate. But the Astato 30 gram is not easy to negotiate. There is a
outback device very helpful to re-engage to the true lumen, but our back device make a artificial load from the force lumen to true lumen. So after using our back device, we usually need a stenting for the distal reentry portion. So I don't want to do stent for this patient, so I will puncture distal from the distally.
So
Our back device need essentially the
my
extension of the lesion length.
essential point is long attempt for the intraluminal subintimal to internal wiring is not necessary. Just we can quickly switch it to retrograde or the.
Okay.
So we wanted to puncture in P2 level,
화면 좀 보여주실래요?
P3 level.
Because distal landing zone is near the P1 level adductor canal, so distal SFA puncture is a little difficult because there is a shallow zone of distal puncture zone. So we want to puncture distal P3 from the integrally today. As you can see on the screen, PowerPoint slide, distal P3 puncture. This image is this patient. So from the anterior view, we cannot see the distal P3, but anterolateral view, around 50 or 60 degree, you can see distal P3. 그 버튼 한번 더 눌러줄래요, PowerPoint?
We can see the angiogram.
Would you like to show the angiogram, focusing on the P3 level?
Okay.
You know, before you go to all that, you might just go to a slightly lower level. You know, you're re-entering at a point where it's heavily calcified at the distal cap. If you go just a little lower down, you might find it more favorable.
Yeah, Dr. Lee, that's the puncture.
Yeah.
This is Dr. Urasawa.
Dr. Urasawa taught me this technique. So he's my teacher, and I will do puncture distal P3 by Dr. Urasawa's technique. This is the puncture portion maybe here. This is maybe ATA, and this is TP trunk. So I will puncture here. From here, I will insert the wire. I already give lidocaine. 지금 아프세요, 환자분? 지금 아파요? 리도카인 좀만 더 줄래요? 이렇게. And first of all, I rotate the patient foot internally rotated. Okay, 됐어요. 저 내가 줄게. Okay, from here. Okay, 들어갈게요. 지금 아파요? 괜찮죠? 네, 오케이. 자, 지금 컨트라스트 주세요.
Hi.
오케이, 컨트라스트. Okay, can you see that? Is the P3 here?
Okay.
P 나오나 봐줘요.
Just a moment.
다시 컨트라스트 한 번만 더 줄래요? 컨트라스트 한 번만 더 줘요.
So as he's doing this, this really points out the value of reentry devices and what they bring to the table. I think you can choose between a number of them today, but I think this would be a pretty straightforward reentry case.
That's great.
And then now he's, of course, reentering below.
피 나오죠? The blood is coming out from the vessel. Can you see?
Which will hopefully facilitate this, but it's not guaranteed that this will get the two lumens back together.
Yeah, I was going to also mention
this is 7 cm
for
long.
heavily calcified vessels many times that I don't use it often, but the anterior device can come right up to it because it's relatively narrow.
Anterior is another good one, especially for smaller vessels and when the throw distance is not too long.
Exactly.
In this case, it looks like they're pretty close to the true lumen. They're not too far out, not too deep, so you should be able to pop back in.
In this particular situation, I think the reentry can be more favored, right?
Absolutely. I mean, this is a fairly straightforward reentry
right.
case.
Yeah.
Because always the retrograde approach is not easily do the kissing wiring.
Very easy.
But we may sometimes we need the double balloon technique or another CTO wire to the retrograde.
Maybe I think a reverse cutter will be enough.
Dr. Lee, it's Dr. Garcia from Boston. You made that look very easy. Can you tell us what is your plan for access here? Is it just going to be a support catheter, or are you a person who puts a 2 or 3 foot sheath in?
We're going to use a sheath technique. This is a command guide wire, and I am following the command guide wire with the CXI 018 comparable CXI by C3 technique like this. Okay.
Actually, I'm Kim from Busan Veteran Hospitals.
There goes the CXI.
The type of CXI catheter is angled or straight?
Yeah, this is a small angle.
Small angle type.
잡아줘요? 오케이. 저기다요. 그대로 밀어라.
So even literally, personally, I think like a V18, I initially attempted the intraluminal attempt first. Then if it's not feasible, then we can do literally the subintimal.
세게.
그래서 와이를 하지.
Which wire are you using, retrograde?
밀어봐. 그냥 밀어. This is command wire.
Command
더 밀어봐.
ES.
Command E extra support. I start to 줄래요?
I start to training. Yeah. So already we ballooned the mid portion of the SFA, so we wanted to intraluminal wire with a hard wire.
써도 되는데
Also, I still say if you come just a little lower from above, you might find a soft spot where you can re-enter with the wire.
Shaking.
ECC 시린지에 줘봐.
I think the 14 wire versus 18, it can be physician's preference, but I personally feel much better with the 18 system because the shaft support is very.
However, CXA I start to have some problem is why is stuck. The why is expanded with the water.
18 CXI, you can use the 18 system, and then 18 V18.
I like 14 system.
This is I start to 30 gram. This is 018 comparable system because CXI is a 018 comparable system. So I am using 018 comparable I start to 30 gram for the puncture of the distal cap of the CTO segment. 잠깐만, 내가 할게 그냥. 잠깐만 있어봐. This is very hard.
I'm not a big believer in these specialty devices for crossing CTOs, but there's these devices which are coming out now to kind of anchor you with a balloon, and then you can pass your wire through it. And these would be the types of cases where it would actually be useful because it'll give you more support from having to go retrograde or antegrade.
Yeah, he's suffering from a lack of support there.
Yeah.
좀 빼줄래? 와, very hard.
Just a moment. Okay. 천천히.
Bob, what about, I know they balloon proximally, but would there be any benefit of just trying a new course from above?
I think so. I would continue working from above. Personally, I would come down to the level of the wire there where you have reconstitution because he's barely subintimal, and then take a high gram piercing wire with angulation to try to pierce back in if you don't have an N-tier or Outback or Pioneer.
In case of a proximal entry from proximal tibial, once the 18 or 14 wire cannot pass, I'm quickly changed to 4 French radial sheath. Then we can use with the 4 French glide catheter support, you can do the 3-5 subintimate angioplasty from the distal. That is easily can pass.
This is proving to be a pretty hard fibrotic cap. Even if he is able to penetrate it, you still have to connect the two and cross over between true and false lumen. So at some point, he's going to have to pierce the layers anyway. So.
Yeah, I think for that purpose, maybe tape-out wire should be used.
So we need slowly advance with rotating, make some crack. Take it easy.
You know, right now we can use 14-inch wire, tape-out 40-gram, 40-gram wires, and also we have 60-gram tape-out wires. And quite recently, we started to use 100-gram tip weight or 14-inch wires for this purpose.
100 gram?
Yeah.
We don't have that. Who makes 100 gram?
FMD, Future Medical Device.
아파트 20조.
Did you just say there's 100 gram tip wire?
100 gram.
You have 100 gram in Japan.
I remember when I was a fellow that the strain gauge...
Non-tapered.
The strain gauge assessments on what you got was tough pushing was about 1 gram.
What sort of wires they are using at
they're using stud wires, I guess.
So, Dr. Lee, how about just coming down from above a little further to the point where your catheter from above is beyond the cap, and then try to use an angled wire, a piercing wire, and see if you can just pop back in. You have a good marker for it. It looks like this is proving to be very hard.
V18? V18 has a strong shaft, although tip is not strong.
Yes, we want to use it, but after the failure of Asato, we want to use it. Then if we fail with 018 or 014 system, I will use a 4-inch thermosis for the 035 system for the subintimal digging.
Or just use a tail of the guide wire.
Yeah, exactly.
Can you inject the dye from the proximal SFA or proximal common femoral and see how it goes from the
Yep, great.
Okay.
So which wire did you use?
This is Asato 20.
20.
Okay, digging 안 되네.
Just a moment. Just a moment.
Asato 20.
Because the 14 system and the maximum is Astato 20 grams. So 18 system you can use Astato 30 grams. So that will be the final choice.
It's certainly going to make a crossing. The question is, will it rendezvous with the other one? But it should. It should get close anyhow.
It's remarkable how fibrotic this is, because there's really not a lot of calcium there.
Yeah.
It's just a very fibrotic.
Dense fibrous tissues.
It's old occlusion. So this is always the fooler where you think, oh, they're touching each other. And then when you go to the oblique view, they're completely opposite.
So I want to inflate the proximal balloon.
Yeah, he's going to try to pierce in
Okay,
there.
조장.
보여줘요.
Okay, okay, 잠깐만. So I wanted to insert the wire more.
Might be helpful to give us some oblique.
안 따라 들어간다.
잠깐만요. 조금씩 들어가겠습니다.
튜브 좀 반대로 돌려봐 줄래? 좀 더 돌려봐.
Pretty close. Yep. Neither one's
Yeah,
far
okay.
off.
They may have already fenestrated this
Okay.
if they're lucky.
So I wanted to remove the balloon. Okay, balloon.
So, Dr. Urasawa. Dr. Urasawa.
Yes.
Okay.
Could you tell us how to do compression the puncture, retrograde puncture site, especially just in case of failed procedure? So this case is going to be successful, but in some cases, retrograde approach can be unsuccessful. Could you tell us such kind of
Yeah, that's a good question.
Microphone.
The reason is I don't fail.
기다려보세요.
014 컴퓨터 부시스 있죠?
마이크로 쓰세요.
have you experienced a kind of like a nightmare complication?
No,
Not yet?
actually I have no experience with failed CTO crossing when I use the bidirectional wiring. Always success.
Because even Astato 014 system is test the reason, but CXI catheter cannot follow the reason. So CXI is a 018 comparable system. So we want to change micro catheter to the 014 comparable trailblazer to insert the distal entry. Because there is a gap between wire and 018 system.
So for the audience, he's ballooning from above to try to pierce from below. You can really do any combination. You can balloon from below and pierce from above, or do both, just to try to open layers in order to pierce. So they've chosen to minimize the size of the equipment that's going into the infrapopliteal artery for obvious reasons, and so they're doing their ballooning from above. But really, you could approach it either way, or in combinations.
You know, problem is that if you puncture the popliteal, you can place a 4 French or 3 French cheese, and you can have a strong backup force. these microcasters, they don't have a good backup force. That's a problem with this kind of the punctures. So even though it's pretty close, you cannot penetrate due to the poor backup force.
잠깐. 말 잡고 있지? 밑에 보자. 여기가 지금 들어가기 어렵지. 살짝 당겨줄래? 오케이, 됐어요. 학생, 왜 보여줘요?
No.
Very hard.
버티는 벌려놔줘.
You should look below. Dr. Lee.
Over the wire balloon 하나 줘봐요. Yeah.
So I wanted to use the balloon.
Could you tell me the tip?
기다려봐.
For this situation.
Even the trouble is because of the lubricity, it's not easy to follow the wire. So I think that in this situation, best way is to insertion 4 French radial sheaths and switch it to 3-5 wire system. You can easily do the rewiring bi-directional approach.
I want to try once more with O 14 guide wire comparable over the wire balloon, small balloon to dilate the initial.
Just a moment.
Yeah, it's worth mentioning where he's punctured the popliteal artery. You really have to make sure to take care of the puncture site afterwards, because bleeding in that compartment can lead to nerve compression and injury. And I think they are minimizing the size for good reasons because of where they've entered. If you enter way low, of course, a very compressible right above the ankle in either any one of the 3 tibial perineal vessels, you don't have that issue. But up here you do. So, they're staying with very small equipment for that reason. I think that's a good reason. So while they're working here, we're going to go back to the first room to get a follow-up on that iliac common femoral case. And we'll come back to you, okay, Dr. Lee? Hi, Mark.
Hey, Bob. So we've had an interesting go here. We kind of came up with a midway strategy, kind of halfway between what we had discussed. And that was, as we looked more at the profunda, it seemed that the profunda was stenotic at its origin.
Yes.
We thought about a 50% compromise in the common femoral. And so we thought, well, maybe we'll just balloon the origin of the profunda and then treat the common iliac on the right. And it turned out that simply traversing the bifurcation was incredibly difficult. We tried a variety of wires and catheters, and it turned out that the common iliac artery and the degree of calcification, let's take the balloon out, was really restricting our ability to do anything. And so we kind of took an alternative tack, and that was to put a sheath into the right common femoral. So we put a 6 French sheath in, measured a pressure gradient. Turns out there's a 50 millimeter pressure gradient at rest across the common iliac artery.
Not surprised.
And so we thought, with that information, taking care of the common iliac actually may make a huge difference in his clinical condition. And so we're treating the common iliac right now. We've just used a 6 millimeter balloon, and we're going to measure a pressure gradient once again, but I think we'll just stent the right common iliac, try to do that without damaging the right common femoral, and that may be the simplest approach, kind of a keep it simple, stupid approach.
Well, it's certainly reasonable given
already,
the high-level gradient. I mean, it looked like a very severe lesion, too.
Yeah, we've already increased the pressure in his right leg by about 40. So I think we're going to go ahead and size this up for a stent and get going with that.
Had you not gone retrograde, Mark, the location of this iliac lesion was going to be really problematic from the contralateral side. Was there any other options for you besides coming retrograde for the right common iliac?
Could go brachial.
I think that trying, well, I suppose we could have gone brachial. I certainly think that contralateral retrograde was not going to work.
No, that'd be tough because narrow angle bifurcation.
we're going to take a shot here and see what we have after our initial balloon inflation.
Very heavily calcified.
Yeah. And it looks like the origin of the left common is relatively spared. I think we're going to try to keep this just with a stent in the right common.
Yeah.
And we'll pull up the image of the 6 millimeter balloon to kind of get an estimate of what size to use. It looks like we just have to get the origin.
So this is the kind, Mark, where sometimes we sit there and say, you know, you pre-dilated, it's very calcified, eccentric. Bare metal balloon expandable or endograft? You know, that brings up that question.
I think that's, you know, if you look at the COBAS data, this might be better with endograft. I think in this case, we'd like to use the smallest possible sheath. I think probably what we're going to do here is just use bare metal balloon expandable. We're going to pull up the image of the balloon here. We'd used a 6 millimeter balloon, and we'll just kind of compare that diameter. I think something on the order of a 7 is going to be completely adequate here, because the distal vessel has a lumen which is about 6. So probably go with something like a 7. That's a 4 centimeter balloon, something along the lines of like a 729 balloon expandable. And we'll just try to park that right up here.
Yeah, it's reasonable. You can always make it bigger.
Yeah, choice must be balloon expandable.
That's right.
Short, but problem, what is your plan for the SFA? Because before the SFA treatment, it's not good to do the stent implantation in the iliac, because if either you brachial approach or the contralateral or the distal SFA, always the device positioning, you have some chance of a stent migration immediately. So final stenting should be done. So
I certainly don't want to deploy the stent high.
Yeah, once the SFA
I must say that simply traversing this aortic bifurcation with this degree of calcification was a challenge. So I think that has to enter into whatever we decide on the SFA. And frankly, I'm pretty optimistic. If he's got Rutherford 3 symptoms with a 50 millimeter rest gradient, I can only imagine what that gradient is with exercise. I think he's going to improve substantially after we treat this. He's got a really robust system of collateral. So I would follow him clinically after we get the stent in.
Mm-hmm. Yeah, certainly having a stent there would make it harder to come back later and go up and over, but the basic decision's been made to probably manage the SFA either medically or surgically and not with intervention. So I think it's probably okay, huh?
Yeah, we're trying to, one of the things going through my mind is what's going to limit our options the least. I don't want to burn any bridges that we don't have to. Do we have that stent ready to go?
Yes. 739?
739.
For next. 739.
739 I think is going to be a little long. Do we have a 729?
29, 20거 없어. I'm just
Because you can see that 4 centimeter balloon hangs up into the aorta, and we really don't want to hang
even a
this very
719 is probably long enough if you have even shorter.
I think that's right. Yeah, I think a 39 is going to be more than we want.
It would certainly make it harder to go up and over.
Yeah. I don't know. Which image do you have in there, Bob?
The ballooning.
The ballooning. So you can see I have the advantage of having both images, and the origin of the hypogastric is right at the end of that calcium border, the inferior calcium border in the common iliac.
I think 39
so I really
is
don't
too
want to
long.
extend. Yeah, I can't see any benefit in jailing the hypogastric.
No. A 19 will do it if you have 18 or 19.
Yeah, I think that's right. We're seeing what we have here.
It looks like he also has, some
let's
adventitial
use
staining
729.
already from the just that balloon. So I pay close attention to how we go up and how much we dilate this calcified
That's
vessel.
why I was mentioning the covered stent.
Yeah, no. But I think for all the reasons Mark described about trying to keep it simple here and small, and the common femoral becomes very important. But here I think COBAS is the useful data set.
the other thing we have to discuss about is maybe the type of the lesion, because this common iliac artery has very eccentric calcified lesions. If you use the bigger stent, maybe increase the risk of rupture or losing.
Yeah, I like going smaller. You can always post-dilate with a larger balloon.
Heparin's been given.
In reality, it's probably an 8-millimeter vessel, but I would
Mark?
agree with a 7.
Excuse me, Mark. So the
Yes.
this patient's systemic blood pressure is too high. So I have a great concern of the possibility of the retrograde dissection after the bone expander stenting. So don't you care about the blood pressure in this situation?
We've kind of been working on that. Yeah, we've kind of been working on that, and I share that concern wholeheartedly. Do you guys like that position?
Yeah, it looks good. Maybe a puff. I don't know if you can fill retrograde. You probably can't.
We can give it a try here and see.
If not, the
We're kind of basing it on the, are we dry on contrast?
Yes.
We've been basing it on on the replay, and there's kind of a dot of calcium,
right,
that I think helps to guide us, but we'll go ahead and do a Sene run here.
They want to be, maybe a millimeter higher.
Yeah.
Pretty good. Millimeter higher, maybe.
Maybe 2 millimeter more.
That'll do it.
Looks pretty good.
For right or wrong, I think that's it.
I'm going to try a shot through the contralateral side and see it.
Right, that'd be good.
Looked like we may have had some streaming, and that may make me inclined to put it a little bit higher. So we'll do a contralateral shot here. I think that's pretty good.
That's pretty good.
Yep.
Perfect.
Yep.
All right, we'll go ahead and start to deploy it right there.
So this
And
is
if,
a 7 by 29, or?
Correct, 29. You're right, Bob. I think a 19 would have been completely adequate here.
Yeah, it's a short
And is he
lesion.
experiencing any? He's actually resting very comfortably.
Yes.
I think we can probably go up to about 12 atmospheres. He's not even waking up here.
It's a good example of Glagoff remodeling. You know, the very deep wall calcium suggests how deep this vessel is and how large it is.
That's good. I think in good shape. So I think that really looks like it has fully expanded. We'll go ahead and get the balloon out. Advance the wire there, please. And now we have simultaneous pressures, which are pretty much overlapped. If we could show the pressure monitor, then I think it would be good. We talked about blood pressure management. If we could give maybe 5
nice,
of metoprolol IV, that would be good.
That's a great result.
Nice.
Yeah, so I think certainly from the standpoint of pressure data, I would be quite surprised if he's not improved. We'll do an angio here.
That looks great.
You know what the enemy of good is?
This great placement looks just right. That's one you can, I think, go up and over again if you need to.
I think that's right. If we really had to, you can see there's a stenosis in the contralateral common also. That may be an issue. As ABIs are almost as low in the left leg as in the right, but his symptoms are more in the right. And this is one also where, you know, there's no question that that is not the normal diameter common iliac, but I must say I don't feel compelled to push it at this point. He's got a 0 gradient, adequate lumen. I think this is one where if we have no complications, we've done a great job.
Yeah, you have no gradient at all. So who would quit now? Take your winnings?
Yeah, walk away.
Walk away.
But I think, you know, one of the opportunities now would be this kind of combined hybrid approach. If they're going to do anything, they could even patch him and get that origin SFA open for you. And if you really want to do an endovascular therapy at that point, you could do it to that right leg, should that become necessary. But I think it gives you every opportunity to come back and fight another day.
Yeah.
So it's probably
Yeah,
worth...
I'm perfectly happy to.
Yeah, so Mark, let's say, just theoretically, the patient's still claudicating afterwards, grade 2 to 3, even though the iliac's fixed, and so revascularization of the SFA is now on the table again. And you do an ultrasound and you don't really have good veins, so you're looking at prosthetic. So would that change people's opinions about intervening on this versus operating? So in that case, if you don't have good vein and you're looking at a prosthetic bypass, who would intervene and who would operate? I would intervene myself. Any others on the panel? Not many. Most would still operate.
I want to check the right common femoral by sheath injections. It's a very small size vessels on the common femoral, so you'd better check. What's
Why don't we do that right
now?
Yeah,
Mark, could you inject sheath injections with the DFA and the SFA and the common femoral by the angle of view?
And we're going to.
Okay, good idea. Get a good view.
Rotate it out RAO.
See what the sheath looks like.
Bob or Mark, just more of a stylistic standpoint, the distal vessel where it reconstitutes bigger is about 8, maybe bigger. Would you ever post-dilate the distal end, the more proximal end of the stent to the sheath now, just so that if you did come in retrograde, you're not getting behind it?
Possibly. I mean, here it looks like he has apposition and it's flared out okay, so I don't think you're obligated to here. You know, Mark's approach is take your winnings, and I agree with that. By post-dilating further, you may create a problem or, take on the risk of rupture. So I think it's reasonable to accept it. In looking at the final image, it looked like the proximal cells were flared at the top. So I don't think you run a big risk of getting behind it, and you could run some risk of creating a perforation if you keep dilating.
So can you see the common femoral injection right now?
Yep. Yeah. Yes, we do. That profunda is pretty severe.
How are you going to stop?
My thought was, we kind of discussed if we could easily get a balloon down there and dilate it, and I have to say that particularly with the stenosis in the common iliac, just traversing the bifurcation was a tour de force, and we finally said that we'll keep it a little simpler and just do the common iliac today. Now that the common iliac has been treated, it might be easier to get around and to treat this profunda in the future. So that could even be an intermediate step. You know, Bob, you were saying if he claudicates badly, would you do endo or would you do bypass? One in-between step might be to see what you could do with the profunda and see if you can improve symptoms simply by doing that.
Sure. Now, looking at that,
I have to say, too, that I'm pleased that.
Now, that being said, Mark, I would say this has all the hallmarks of not doing well with a balloon. You know, it's eccentric, heavily calcified. So I'm not sure I would balloon it now. I think this is something that I would be prepared to do something like atherectomy, for example, to reduce the eccentric calcium burden to assure yourself you get a dissection-free result. This has the hallmarks of dissection written all over it.
Yeah. There is one small area. If you look carefully at the tightest area on the profunda, just after its origin, there is a lack of calcium right at that area. But I think you're absolutely right. The chance of tearing this vessel is high, and I think right now I'm pleased that we don't have occlusion with the sheath. I think this is something that we can let the ACT drift down, do manual compression, and get out of Dodge.
Yeah. I would agree. There's no problem coming back later if you need to. Very nice result. Any other comments? If not, thank you very much. We'll go back to the other room. Appreciate your fine work.
Thank you.
Yeah, great work.
Thank you. Good job, everybody.
Thank you.
So now we'll go back to the other room. How are we doing, Dr. Slees?
Yeah, we already crossed the region.
This is a O14 balloon, comparable balloon, 1.5 20 meter Almada XT, and that is a stator. But balloon is not cannot test the distal CTO cap, so we changed the guide wire to the command at this portion. Command wire can make a route like that, and it can be go forward for the proximal portion. So command can be easily can go the proximal subintimal space. Then after the balloon dilatation of proximal portion with the previously inserted 4.0 150 millimeter balloon, then command guide wire can pass the region like that. This is a typical technique of reverse cart.
Yeah.
Then after passage of a holder CTO segment with command wire, command guide wire is highly resistant for the hip damage, so it can easily go to the guiding system like that, and then we make a loop from the left femoral to the right palmatial artery. Then we insert the 018 comparable 4 millimeter long balloon like that, and while dilating the distal SFA segment, guide wire was removed from the palmatial artery. Then guide wire antegradally inserted to do for the procedure like this. Then puncture site is
compressed with blood cup with more than 30 millimeter mercury more than the patient blood pressure.
Okay, 좀 보자. 잠깐만.
So at what level did the command wire re-enter? Did it re-enter in the common femoral or in the SFA?
Common femoral more beyond the common femoral, maybe external iliac artery.
아까 15까지. 밑에 보자. 밑에 비나니 밑에. Okay, play here.
Okay. We enjoy usually balloon dilatation more than 2 minutes. So already we. This is 4.
What size balloon is that?
4.0.
This is 4.0, 200.
Yeah,
200 millimeter. 몇 미리야 저게? 150? 200. 200 왜 이렇게 짧아 보이지?
So time off 다시. So now we time on.
Yeah, so tell us your plan. So tell us what you're thinking as far as how to finish this after you balloon. What are you thinking?
We'll check the angiogram. Angiogram first.
Angiogram first, okay.
Then if there is another significant dissection, we will do DEB angioplasty for the whole region of CTO.
Okay, panel, how would you finish this? Subintimal pretty much all the way, most of the way. Lawrence, you asked the question. How would you finish?
I like for length here, I think that if you're going to fall back on the data, the only data is the covered stent design, but it's fairly loosey-goosey, and they had a lot of challenges with it. So I think of all of the designs right now, I still like the Supera stent and interwoven nitinol stent here. The challenge will be how close you have to get to the origin and how good you are at deploying it there, but I think that would be our first initial thought.
Oh, cool.
So bare metal stenting. Others, DCBs, DES, endographs. This is a task D. How about the rest of the panel? How would you finish this?
During Canada, long CTO is a pound, but the problem is after that, end up long stenting. That's the problem of this kind of disease. So there's no solution for that. Definitely DCB doesn't work. It's too long. The balloon procedures, you can't get optimal results.
All right, so that's
and
point.
Maybe the endograph, but for the crowd count, the initial treatment, would like to avoid the endografts. So I don't know. I have no idea.
So with a deliberate subintimal approach and POBA only, the literature would say largest series is out of Norfolk, Virginia. Only 2/3 are still open at 1 year. And of the 2/3 that are open, reintervention's frequent. So POBA alone for a subintimal long segment subintimal dilation doesn't carry a very good long term. And that's where at least spot stenting has come into play either at the site of initial entry and re-entry or at points where you have a high-grade residual. So balloon alone frequently doesn't yield very good long term.
I agree.
Our common practice is entry point spot stenting.
Exit and entry points, spot stenting.
Yes, exit point is well maintained. Sometimes we leave it, but mostly it's not so good. Then we have to do the spot stenting.
So here at re-entry, you have a definite grade D dissection. It looks like pretty substantial dissection. That'll, in my eye, need a stent for sure.
5.0 제일 긴 거 해주세요.
And we also see the access site in the popliteal flowing.
Yep.
Down below. It's not.
Yeah.
So we have to keep our eye on that.
So blood cup is off during the angiography. We elevate the blood pressure.
You know, how many times have you gone in there with? I don't do the spot stenting approach, but you know, I think it makes sense. But the question is, you know, it took a long time to cross the CTO, and if you just spot stented it, and then you come back for a reocclusion, you can't connect the two dots again. It would really just get me really upset. So I generally go with a full metal jacket. Just my 2 cents.
So I mean, these are
Lorenz,
problematic.
I don't understand the spot stenting. Where's the spot? Where's the sweet spot to stent?
Yeah, so I mean, most people would say on these subintimal cases, proximal, where you go subintimal, and then re-entry point at a minimum, are the two spots, proximal and distal, and then areas where there's a high-grade residual in between. My experience of that has not been so good. I've had recurrences in areas that are non-stented and so forth. So it's, you know, unfortunately, I've evolved over the years more to full metal jacket now. Whether that's right or wrong, just spot stenting hasn't been that great. Now that's prior to DCB. Now DCB applications here are, I think, you know, it's a real option for this patient.
Yeah, I agree with that idea. In Japan, there was several clinical trials with regard to the drug coating balloon and several other developing devices, but there's still ongoing project where we can use just balloon and the self-expandable stent. So originally, in this type of lesion, I usually use full metal jacket stenting. The result is horrible. So the 3 years primary patency rate is about 50% for task D lesions. So that's the major reason I switched to the spot stenting strategies, as you said, and the entry point and exit point, two stenting, and the middle of them just read them alone, just by ballooning.
Viabon was mentioned only once here, and this is a long lesion with pretty good runoff. You have two-vessel runoff. I see that this is definitely Viabon's a good option here, and good data on the long 25 cm CTOs. You know, and the vessel caliber seems to be sufficiently large, so Viabon's a good option here, and with the 25 cm stent, you're only looking at 2 stents to cover the whole thing. So this is one where I would be thinking toward Viabon.
Yeah.
Is this your new balloon?
Yeah,
yes, we changed the balloon for a little bit bigger. This is 50 millimeter, 200 millimeter length. So we want to inflate the whole SFA region for a prolonged time. Then we will check the angiogram again.
There you go. That hard spot finally yielded.
This is 15 centimeters or 20? What's the length?
20.
This is 20.
15. And it's a 5
This is 20.
5 or 20 centimeter.
It's a 5020.
20.
Okay.
So
20.
A good 35, 40 centimeters.
Yeah, it's the whole thing, right? 35 to 40.
So we want to change with 014 wire to the implant steep or 35. Because of DB need usually the 014 or 35 for system. Okay?
with the wire out of the antegrade or the retrograde portion, are you Dr. Lee? Are you managing the anterior tibial by manual compression now, or what are you doing with your retrograde?
Yeah,
axis?
no, blood cup.
This is compressing by
It's got a
blood cup
leg cup.
with
Oh,
150 millimeter mercury. Yeah.
I'm sorry,
Can
I
you
did
see?
not see that. Thank you.
Yeah.
But it's not fully containing it. You know, it's still leaking somewhat.
Yeah, some breathing.
Yeah, so
In that location,
now
that's
is
important.
break time.
Yeah, that's
to
right.
control.
There is one of the tips is just ballooning from inside as the puncture point for 5 minutes or 10 minutes. You can get nice hemostasis.
Yeah.
And also, if you cannot get the hemostasis by just a simple ballooning, you can use a thrombin injection around the artery.
Okay.
With the balloon inflated.
Yeah, that's right. That's right.
Right.
30, 여기까지 30부터 하면 되겠다.
3분에 3분.
Okay, we have about 17 minutes left or so. Be interesting to see how this looks after angioplasty, to see what the vote's going to be as far as how to finish here.
Yeah, thank you.
TV가 4개 필요하겠다.
So, Dr. Lee? Dr. Lee?
We are all Dr. Lee.
Yeah. You're right.
Both
So,
Dr. Lee.
how long will you dilate the balloon? 3 minutes, 4 minutes?
We usually 3. We usually 3.
All right, so you're going for a POPA strategy here.
3. We need
Okay.
6 minutes and take a time.
I think you're going to need to do the reentry point at a minimum. You look pretty dissected.
Okay.
잠깐만, 천천히. 아직 안 플레이 안 돼.
시스 빼고.
잠깐만, 아직 디플레이시 안 됐어.
I had that in the United States. You can use a 30 centimeter balloon in the EVD market. Is that correct?
30 centimeter? No, our longest is 20.
That's true?
Yeah, they make 30s, and you can get them in Europe.
Okay.
We don't have them in the US.
Okay.
Actually, 210.
Some
is the
company
longest.
make some company make 250. Armada long balloon is 250. That is the longest balloon in Korea. In plate.
Yeah, our longest
I
is
heard
210.
maybe Bado veterinary company make 300 millimeter. 지금 아까 30까지라서 한 번 더 해야지.
So my friend Dr. Lee.
If
So my friend Japanese guys emphasize the need for eyebrows before and after the wire crossing. So could you tell us the eyebrows used in Korea for in the field of peripheral intervention? Do you use
not
eyebrows
commonly
usually?
used.
Not.
Yeah, not commonly used because of the not reimbursed by government in Korea. So, however, if there's some difficulty to wire crossing and so we don't know exactly the wire location, at that time we sometimes selectively use the eyebrows. And then some dissection occur. We wanted to see the lumen, minimal lumen area to decide the stent or not.
히머헤드 아니지? 지금 조금 낮다.
So you guys are trying to end up by balloon procedures?
Yeah, we're going to get a picture here, huh? We're all anxious to see.
저기서 한 번만 더 하겠다.
Always peripheral intervention is very boring. Okay.
Well, that's the major reason that we need a long balloon.
Yeah.
If we can use 35 centimeter balloon.
Yes, this is my hope. Okay. 저장하고.
So after balloon angioplasty, we try to if the relatively clean, we want
This
to
is a 20
apply
cm
DV.
balloon, so we're looking at 40.
At least.
At least. Probably 45
Yeah, yeah.
cm. Very long lesion.
3 or 4 dB is required to this patient.
And here's one of these unmet needs. Is it always goes back to the origin, right? And there's no way to place a stent at the origin of the SFA without impacting your profunda. So here's where the parallelogram versus a simple rectangle becomes important.
Yeah, it may be helpful to do the femoral shot in the ipsilateral oblique to make sure that the reentry point hasn't created a problem at the bifurcation, rather than the AP view. Because we absolutely want to make sure that's intact.
So of the balloon angioplasty, we applied Lutonics from the body. Okay. Stand by.
Are you going to do DCB? Is that what you're saying? So it's an interesting area for DCB. Most of the trials, as you know, have been on fairly short lesions. There's 2 different long lesion registries, but, quote, long is still only 15 to 19 or so cm's, not in the 40 range. So there's really, it's uncharted waters as far as data outcomes on DCB and very long lesions. Same as pretty much the case for DES. Their registries do go a little higher up into the low 20s, but when you get into the 40 cm category, really the only organized data above 20 plus is with the Viabon so far. But it'll be interesting to see how data accumulates on DCB and DES for very long lesions.
Okay. Check angiogram.
But thinking of the geographic miss, how long for the DCB is allowed to use? 35 centimeters?
DSA 누가 풀었어? DSA 좀 줘.
Huge dissection.
Okay.
Wanna do here again?
Okay.
자, 커프 좀 풀어줄래요? 풀었습니다. 그래. 잠깐만 밑에 피 나는지 봅시다 그럼. 드릴게요. Breathing is completely controlled by curve compression.
Yep.
Okay.
And distal entry portion, there is some dissection.
Yeah, the reentry still has a pretty fair dissection. Approximately, it doesn't look too bad. Well, what's the vote?
Stent.
I think you're getting better.
Oh, the whole thing, or just?
I think what's driving me to stent it, not just to be flippant about it, is that you still got a lot of collaterals around the distal SFA, and I think that there's still that dissection, which probably tells you that that is more significant than it appears angiographically. So I think you're going to come back and fight another day if you just ballooned it alone. I think you're going to have to stent that dissection plane
So
distally.
the distal dissection for sure.
Yeah.
All right, who wouldn't stent the distal dissection? Who would leave it? Who would walk away?
Okay.
Nobody. There's strong votes here for stenting that dissection distally, whether you stent the whole thing or just the distal. I think you have one approximately too, honestly. Right at the reentry point, you can see a double shadow right below the pelvic bone. So you have them at both ends.
저 검은 것 좀 없애주시죠. 그냥 이렇게 한번 계시고 쏘세요 지금.
Well, we'll ask both Dr. Lees, what are you thinking as far as how to finish this? Runoff's pretty good.
Previous one. Okay. This is the angiogram after prolonged balloon dilatation. There is some dissection at the distal entry point, but proximal portion is quite good. So I think we don't need the stenting for the distal reentry portion. So we want to do just balloon DCB angioplasty for all the way the length of the CTO segment.
Okay, so distal reentry point for sure. I would inspect the proximal part in more detail too under higher mag, different views, because it looks like you may have one up at the top too. But distal for sure. I think everyone's voting in agreement. So you're going to use a bare metal stent?
No. Just the DV.
He said he just wants to use DCB and leave them alone without stenting.
Oh, you're going to DCB it. Okay. The dissection.
Okay, this one. Okay. Okay. You can see the other company's DB is a unique delivery system. And fill up like this, and then pushing. Okay. We want to avoid geography miss.
No pressure, but we have about 6 minutes left.
Okay.
좀 해줘요. Okay, from here. Okay.
No, 좀
더가?
조금 더가. 조금 더. Okay. Okay.
잠깐만, 좀 더 올려.
So tell us what you have here.
50까지 왔어요. 50까지 온 건데.
좀만 올릴게. 뒤에 얘기해가지고 끝내려고.
오케이, 됐어.
잠깐만. 이 정도 어때?
됐어, 오케이.
49.
You
오케이,
agree?
여기다 하시죠.
Okay, go.
Template. This is the Tonix 120 millimeter drug-coated balloon. And 천천히. Timer.
Rutonix.
We're afraid.
Nominal.
Rutonix.
Okay.
We may need 4 DEB for the treatment of this region. We expect.
Okay. Next.
So you're going to DCB the whole thing?
Yeah.
Okay. And then if there's still a dissection, a spot stent?
38.
After DB, we decide.
Okay. I think the distal range, you probably still need a spot stent.
So, Dr. Yokoi,
To avoid a mechanical problem.
Dr. Yokoi, I have a question about dissections. So we are now wondering what is a semicant dissection after bone angioplasty. What is a semicant dissection? What is a non-semicant dissection? We cannot measure the pressure gradient in the SFA because of overestimation of the pressure gradient. So what is a semicant dissection? Actually, you can see the non-flow limiting dissection here, but we are now wondering what is a semicant. Please tell us about such kind of thing. Dr. Yokoi or Chairperson, could you tell us about such kind of thing?
Like you were asking about the meaning of the dissection.
Sorry?
Could you repeat your question again?
Push.
Okay. DB 주세요.
전에 사진 좀 올려줄래?
Could you please repeat your question again?
Yeah. So we are now wondering what is the semicant dissection.
Yeah.
So in this case, we can see non-flow limiting dissection. But I'm not sure this dissection is semicant or non-semicant.
Yeah, sure.
So how do you define such kind of thing?
So it's hard to know. You know, flow-limiting dissections where you see a reduction in flow are associated with a high incidence of subsequent thrombosis of the vessel, for sure. So if you see any flow reduction, I think that's commanding, you know, to do something to prevent a mechanical occlusion. This one's what I would call a grade D. It's a deep dissection, and it's pretty substantial. Flow in it's still good. You could go the route of saying, well, we'll see if it heals, and that's a possibility. But knowing that at least a third are occluded within a year, you know, based on just POBA alone. Do you want to take that chance? And that's even in the absence of grade D dissections. That's just overall. Most of us, if we see a real deep dissection like this where the lumen is reduced substantially, we'll put in a spot stent to prevent occlusion.
Even compared to the balloon-induced dissection, the DEB, also with dissection, the durability is more nice from the data. In our Korea, we have involved in the global DEB registry, and our the spot stenting, the bailout stenting rate is around 25%. So global registry itself is 18%. So it means that 1 out of 5 patients have some chance of bailout stenting, even DEB application. So I think that still mechanically, some patients we need spot stenting after the DEB application.
Right, and the application of the Lutonix here is not going to change the dissection. It's going to look the same because it's been ballooned for several minutes already with the same size balloon.
Yeah.
So I think the assumption, we may go off live here before we see it, but the assumption will be that it's the same.
Right.
In which case, I personally would do a spot stent.
Yeah, I think the question ultimately goes back to the data, right? So impact was like 23%. Lutonix, I don't know their full data set, frankly, but say it's about 25%, and Thunder was about 25% on CTOs. They've never borne out that stuff where they look at specifically the CTO market, but that would be really useful for things like this. Particularly, as you know, that the CTOs get longer and longer, and whether or not the global registry plays out to that same level that was just discussed. But, if the answer is that it ends up being, 20% failure rate, then I would think that this is a great opportunity. If it's a 60% failure rate, then I think that it would probably be better to leave an endoprosthesis behind.
The manufacturer or the study indication for the bailout stenting is residual stenosis is greater than 50% or flow limiting dissection. So even looks some residual stenosis 30%, 40%, I think we can live with once we apply the DEB.
Yeah, you would hate to go through all this effort and expense just to have the thing flap occlude, shortly after completion here because of the dissection flap. It's an unknown, and it's a wild card in the treatment of this, and so most of us, myself, I would spot stent it for sure. Well, it's coming on 11:30 now, and we're concluding our transmission time. Maybe just get one quick picture after application of this DCB, and then we'll see how it looks, okay? And then we'll have to sign off. You're to be commended for your efforts to get through this retrograde, from the direct popliteal stick. It really shows quite skill.
There is some learning curve, however, if you try to maybe easily accessible any tibial puncture. DB?
We are doing DCB. This balloon is a little bit bigger one. This is 60100, and for the distally we use 250 DCB, and for the proximally we want to use 260 balloon.
So you're going to use one more DCB?
Yes, we need.
Maybe give us a picture before the last one so we can see what it's going to look like. And then we'll have to sign off.
Yeah.
Okay. Zoom out. Okay. Angiogram.
Just a moment.
좀만 더 줄래? 좀만 더 줘. 와이 좀 빠졌다. 오케이. 엔조 찍는다?
네. 오케이.
Okay, so you're going to apply one more DCB, and hopefully it'll stay nicely open. Want to thank you for your efforts. It was really a tremendous case. Thanks very much.
Thank you.
Thank you.
Thanks to the panel as well. Appreciate it. Tough cases.